Let's get this party going, everybody. Welcome and thanks for joining us. Happy June. My name is Matt Giffune. I am a co-founder of Occupier. We're a lease management company, software company. We provide transaction management, lease administration, and lease accounting compliance software to tenants, as well as deal management software to the tenant rep brokers that represent our clients. We are joined today by Chris Wadley, Managing Director of the Healthcare Practice Group at JLL. Chris, why don't you say a couple of words about yourself, about your team, and we can dive into the topic of today's webinar.
Thanks, Matt. Chris Wadley. I live in Houston, Texas. Our practice is a national network of healthcare brokers and other services, third-party services for either building owners or for tenants. We're probably mainly talking about tenants today, since that's what we use Occupier for, and what I spend most of my time on. The product type of, I love that picture. It's like 15 years old. What we spend a lot of our time on more recently is retail type medical product, but also medical office buildings and hospitals are building types that we'll do transactions in. I've got a team in Texas of about 15 brokers. We also built a project management healthcare practice that's doing about $1 billion of construction management right now in Texas amongst about 20 of those individuals. And then we have a healthcare property management group. So again, a lot of our work is in Texas. We do work outside of Texas, mainly driven on the tenant side for some national accounts, national portfolios. And then some of the other folks on this meeting are JLL Healthcare brokers too. So in different markets, we all collaborate on a regular basis. It's a pretty great group. Thanks for having me.
Yeah, thanks for having us. Thanks for joining us, Chris. So just a couple of housekeeping things. I'm manning the controls of this Zoom webinar. So if I don't get to your Q&A or chat questions right away, we'll try to reserve 10 minutes at the end and go through them. Feel free to just dump them in the Q&A and we'll hit them at the end. We'll try to get through this whole webinar in about an hour, but if we wrap early, great. So once again, Matt from Occupier, and we are diving into the evolving landscape of healthcare real estate with Chris. First question here, the format of this, we're going to just ask 4 or 5 broad topical questions and let Chris drop knowledge on us from there. How would you describe the evolution of healthcare over the past few years?
Sure, and I'll try to answer these questions knowing that some people on here already are in healthcare and these are going to be things they know, but for those that are not, obviously the pandemic is talked about so much, but as it relates to healthcare real estate, it created a bottleneck in transaction volume for about 1.5 years, and then that bottleneck started releasing. And so you've also got a lot of federal funds that were directed to support healthcare systems that had financial damage, done to their systems during the pandemic. So you've got effectively like people that, elective procedures and things that are not necessarily as time sensitive were just not done in most of 2020. And so and then all of the financial resources were then redirected from those systems to focus on just basically staying as close to profitable as possible, not to lose too much. And then then there was a compounding effect where it's like, okay, all these projects that were put on hold are back online. A lot of federal funds were redirected to healthcare systems. And so those healthcare systems now have just taken off across the country, not just in Texas, but we've certainly seen it in Texas. So new bed towers, new ambulatory networks where they're going out and developing outpatient facilities closer to the neighborhoods, which will tie into what I'm going to talk about later. But that's on the system side. Another big change has been, a flight to perceived low risk, just smart private equity money, hedge fund money, that sort of thing, looking at healthcare for maybe the first time, or looking at it and investing in it for the first time, and determining that There are for-profit business models in all across healthcare and all across the nation, where you've got business people getting into healthcare. It's not only doctors and it's not only healthcare systems. It's large institutions, and it's private money pouring into building out businesses with the idea that they can scale them up and then ultimately exit, just like you would with any other kind of portfolio retail business. So this could be, some of the new subsectors of healthcare that we've seen that come into in a national way would be like retina specialist and Mohs surgeon and dermatology type specialist and ear, nose, and throat specialist and imaging centers. And these are things that were, maybe just 5 to 10 years ago were much more regional in nature, and now they're becoming nationalized, and they're being inserted into for-profit models. So it again, as a real estate broker, it's translated into a different profile of customer with different drivers into what they're looking for. The large real estate companies have benefited from this, the service companies like a JLL or a CP or other national players, because we have put in a lot of investment in resources and people and technologies to support the growth of these national businesses.
Cool. So the two kind of biggest forces here are the opening of the bottleneck from COVID, and private money coming into the healthcare space, rolling up, certain sectors of the industry that is then creating, larger companies that need services from the JLLs of the world. Talk a little bit about the concept of systemness, because I think maybe we could kind of drive home the takeaway from that first question with the definition here. Sure.
So Systemness is a lot of it has to do with a refocus on operational efficiency by healthcare systems. And so, there's a couple of things that maybe some people don't know. Historically, hospitals have been huge facilities, right? And what I mean by that is like major metros around the country have, hospitals with 200 to 400 beds maybe, and that number has over time has gone down because they're not efficient. And so that's just one example, but a heavy focus on now ESG and operational efficiencies and driving down infectious diseases in the hospitals has again pushed an emphasis on effectively spreading out your services, sort of almost dividing them and then using technology to link it all together back to the mothership. And so that, again, on the brokerage side, that means a different profile of project. On the management side of these facilities, we have a facilities management group that is that manages hospitals. It's just really upped the ante on the amount of compliance that they have to check into, and there are new regs around that, and then the amount of the amount of staff that are required to do this, and there's been a kind of opposing pressures to especially during the pandemic, was to maybe have to reduce staff or try to allow people to work from home, but at the same time it's like leaning more on third-party resources to service some of those operational needs. And so that's enabled our company, and I'm sure other brokerage, other service companies, to add in more services into these. So I don't know if that answers your question, but I think that's what we see from the real estate side of things.
Cool. Yeah, I have 2 follow-up questions to that. Do you think that kind of the pandemic was a learning experience for a lot of these systems, where they were able to identify where they were not operationally efficient and then start to kind of direct resources to shoring up whatever kind of holes they had in their processes?
Yeah, for sure. And painfully in a lot of cases, just having to, having all of the, I'm trying not to have this all be about the pandemic, but gosh, it's just been such a dramatic shift in the healthcare space. And Yeah, I think coming out of it, you're just looking at the trickle down effect of all of the new kind of operational norms now that weren't operational norms 3 or 4 years ago. Telehealth, I mean, it's not something that really has impacted our real estate business, but it is we had a major healthcare system CEO come and speak at our conference 2 weeks ago, and telehealth is a big priority for them, and that is it's not only about keeping patients out of a coming in and taking up an unnecessary seat maybe, but it's also about volume, allowing them to be able to see people sooner, because if you have any personal experience, it's like sometimes you have to wait weeks and weeks or even months to get in to see the right provider, and some of that pressure can be offset by using things like telehealth or allowing a more of a regular visitations by patients that maybe aren't going in to see their primary care physician every year. It's like a lot more accessible for somebody to get on their iPhone and have a regular appointment. And that will over time will reduce the amount of time that people are coming into the hospitals and really ultimately being admitted through the emergency rooms. And that's the big issue for any healthcare system in any part of the country is, effectively preventable issues that are coming in through the emergency room. I'm not talking about car accidents. I'm just talking about, somebody's heart rate is up, or somebody's got, they've let a fever get out of control or whatever, and just not doing anything about it. Then they end up in the emergency room, and ultimately it costs the healthcare system money, because the healthcare systems, even though a lot of them are nonprofits, they are businesses, and they do have to they do make more revenue off of certain procedures than others. It's not all about just treating any issue that you have. It's a lot of it has to do with trying to funnel the right patients into the right place, and it's easier said than done.
Yep. The other follow-up question I had to your earlier statement was, you mentioned that the nature of the transaction is starting to change for the tenant rep because of this kind of, let's call it a hub and spoke model of, central CBD hospital, and now looking to kind of spread facilities out, whether that's, regionally or even on a more kind of national basis. Like, what does a transaction look like now? So if I'm Mass General Hospital or something, and I'm going with that model, am I acquiring land and building a suburban hospital? Am I retrofitting an older hospital that might, be dilapidated? Am I trying to find an office building to convert it? Like, walk us through kind of like what what the typical kind of directive is on your end.
The short answer is yes.
To all of them?
All of those. Yeah. It depends on the system. Most systems we've seen are more, they're long thinkers. They're thinking 20 and 30 and 40 years. And so they're building brand new facilities, because the way that facilities have been designed in the last several years has totally changed. And again, back to, older facilities tend to be oversized now. So we've seen, I'll give you a good example, like the long-term acute care space, which is where like you would go if you're going to stay in a inpatient hospital for like longer than 30 days, because you might have had a gnarly accident or you had a stroke or something like that, and you've got to recover and go through physical therapy. That model has changed a lot. What they're trying to do is get a lot more of this that's able to be put like in home health situations. There's a big emphasis on trying to deliver services to the home. But ultimately, I would say like facilities across the country have just been shrinking and getting more efficient, because it's for obvious reasons. It's expensive to build a larger facility, and you don't want unused space and vacancy. And also, the consumers now more than ever, because of everything, the way that people are moving around and working, they want to be able to access as much healthcare as they need as close to the home as possible. And so, for a healthcare system, it's easier to go and build a micro hospital with 20 or 40 beds, and do 2 or 3 of those, rather than building one somewhere. So higher acuity patients going into the main medical centers across the country, lower acuity, more common, like even women's hospitals for deliveries. I mean, they're trying to put those type of which is I've got kids. I mean, it's a very intense experience, but still something that a lot of people go through. And so they're putting that as close to major residential hubs as possible. But then you got like an HCA, for example. So HCA is the largest for-profit healthcare system in the country. They tend to, and I think it is because they're a for-profit, they tend to try to retrofit older facilities and maybe take some of the stuff that other systems don't want and make it work. And that's because they're hyper focused on their stock and their cost and maybe one of the most efficient systems out there. So we see a lot of it. I think the nonprofits are maybe a little bit more long-term thinking, and the for-profits are obviously looking at quarterly share price. And so the nonprofits, maybe the well-heeled ones, can afford to go and almost overinvest in a long-term visionary facility. There's also a lot of partnerships. One other thing I'll say is a lot of partnerships with for-profit businesses now, with the explosion of ambulatory networks. And so healthcare systems are usually pretty savvy on what they don't know, and sometimes what they are aware of is that they're not going to be good stewards of managing dozens or even 100 ambulatory surgery locations across a large area. And they'll partner up with one of these national for-profits that have been doing it for a long time and say, come in and be our partner and help us manage the physicians. By the way, the higher acuity physicians, a lot of them are not married to a healthcare system, so a lot of politics, and they're kind of like athletes almost, or like free agents. They might move from one to another, or they have like a 30-mile region that they cover in this area, but then they'll drive outside that region and partner with a different system. So there's all sorts of reasons why strategic partnerships with systems make sense. And then ultimately that it impacts, for the tenant rep broker, it impacts, again, who our customers are, the velocity of transactions, and for-profits just move faster always. I mean, nonprofits are 3 times slower than a for-profit in almost every scenario. So we do like our nonprofit customers, but we're selective about who we work with. We focus a lot of our energy on the for-profits that have entered the scene because they're just blowing and going.
Churning and burning. Yeah, that's a good segue to the topic, which is location selection. How does the site selection fall into the overall strategy? So we've already kind of laid the foundation for how systems are thinking about their strategy, their network, how they get closer to their customer. How do they evaluate locations?
Yeah, I mean, so JLL is one company of many companies that are doing location analytics. I think we do it in a unique manner because of all of our real estate data that we integrate in. But there's definitely well over a dozen of these organizations that are approaching directly to the end users about their platform, because more than 80% of any kind of healthcare tenant out there are using analytics, I would say, at this point. And that's been a huge shift. I'd say like people like Jeremy on the phone are some of the earliest healthcare real estate experts that started bringing this technology to the table. But now it's almost like it's a must-have, and the reason is, again, I think a lot of it has to do with the for-profit money that's entered healthcare space, and they're bringing best practices from maybe another business model that they had used in the past. I mean, I don't think anything analytics-wise is new. We've been using it for decades with retailers like McDonald's and Starbucks and Chick-fil-A. I mean, it's just kind of like identifying opportunities where there's maybe a mix of a couple of different main ingredients that need to be brought together, and data is now readily available, has enabled healthcare providers, both systems and for-profits, to start doing this. I would say the systems are still late to the game because, again, they're big giant nonprofit animals and they move slowly, but they're all aware of it, and a lot of them are using it now. But the for-profits in the retail space that are out there in the communities and doing dozens or hundreds of locations around the country, that they live and die by the location analytics. And just like, again, you wouldn't go in as a whatever type of retailer you are and not look at the population and not look at the demographics and not have your own key performance indexes identified before you go into a market.
Cool. So I would imagine for each one of these aspects here on this curve that there is a different kind of analysis that has to be done based on what's being done inside the facility, how many people are visiting it. So if real estate's the physical manifestation of the integrated delivery network, how do you square these different types of real estate requirements? Are they all weighed equally?
No. You mean as far as, what's kind of moving, what's growing at different levels? Is
Yeah,
that
I guess if you had to kind of rank they're all important, right? But if where do you get the most attention from your clients?
Sure. So I would say, looking at this continuum of care, that is a slide we've been using for years, and it's good for a good reason. Probably your physician offices would be number one, because there's still a ton of them out there, and a lot of those are housed in lots of different types of real estate. It could be medical office, it could be retail. Now you're seeing those type of offices going into general office as amenity space, especially in New York where you are. And then I would say secondarily, probably, and look, we don't, as a company, we do skilled nursing, but it's not my group's expertise. It's more of a capital markets focus, but skilled nursing's been exploding over the last couple of years. For us, I would say it's physician offices and, probably urgent care, just because, we used to do a lot of ER emergency care, and there's the difference between the two, for those that don't know, is, emergency cares are 24/7 facilities, and they're licensed that way by the various states. They all have laws on it, but they're all by definition 24-hour facilities. Urgent cares are like ER lights, basically. So they're not 24 hours, but they are there is like an overlap on the Venn diagram of like what services you would go to receive at an urgent care and an ER. But urgent cares are, for insurance billings, and also for like infrastructure requirements, more of a retail and a lot less expensive for a provider or a system to open an urgent care location. I don't know what the numbers are, but I bet it'd be 3 to 1. I bet they could open 3 urgent cares for every 1 ER in terms of expense to opening one. So there's been a lot of velocity in the private equity space on both of those. And then the third probably would be diagnostic and imaging. So you can see all 3 of those land on the early part of the acuity care, because there has been a national emphasis, and I would say national as in like the federal government has been emphasizing trying to focus on wellness and not on healthcare. It's more about the health and not the healthcare, right? So it's trying to keep people out of hospitals until they're older when they have to go. We have a very unhealthy population as a country, but there's an emphasis long term on helping our population get healthier over time.
Cool.
So translates to real estate deals.
Right. And I think this is probably the most fascinating thing that you and I spoke about in our kind of prep for this webinar, which is the Medtail phenomenon. I think anybody that visited a city recently or lives in a city, now you're walking down kind of your main high street retail locations and you're seeing actual clinics, whether they're dental or vision or doctors or pharmacies or vets. It seems like every block of retail has some sort of healthcare use on it right now. Why has that happened?
They've been moving out of medical office buildings and into retail projects. It's not that there's necessarily been just a doubling of how much medical real estate there is out there. There certainly has been growth, but medical real estate square footage is directly correlated to population. So any city that's had population growth, which a lot of those southern cities have had that. So any of those cities have seen growth in their overall medical footprints, but it's not like a dramatic shift, right? It's just been a reallocation of where these are located. So there have been winners and losers in this. And, it makes a lot of sense. And it's something that I think that it was happening before the pandemic, and the pandemic probably helped in accelerating it, because for obvious reasons. It's if you're in a city where you drive, you pull up in the parking lot, you don't go through a common area. And by the way, the tenant doesn't pay a common area add-on factor because they're going to a retail site where it's just a rectangle or a box, and they walk in and they check in and then they go to a very specific service. So it's not like you're going into a building where there's 30 or 40 different services in the same medical office building. The other thing is, I would say, is branding. I think healthcare systems have always prioritized branding. I think that as private equity, again, bringing their best practices in from other industries, they acknowledge that, people, just like when you watch the same commercial like 15 or 20 times, it kind of starts getting seared into your brain. It's like if you're going to your grocery store every week and you see right next door a couple of these brands that are not healthcare systems, that are just newly created brands, like an iMart, for example. iMart is exploded across the country with hundreds of locations. It's private equity backed optometry. And so now iMart is one of those things that, people see, kind of like it used to be LensCrafter and all those. There's just in every area of healthcare, it is becoming more retail consumer driven. I think part of it too has to do with insurance. I mean, a lot of people are either not buying insurance these days, or their deductibles have gotten ridiculous. And so a lot more cash payers than we used to have. And so same thing as going and buying, a cup of coffee. You're going to go and you're going to have a better selection. You can get on Google reviews and figure out which is your favorite dermatologist to go to. And guess what? They're probably a brand that's backed by private equity, and it's all intentional. And they're intentionally putting it in retail adjacent to, non-healthcare retail businesses that people frequent. And they're using the analytics to figure out where to go.
I think that's the insurance piece of that is really interesting because, traditionally you think, oh, I have a medical issue or I need to see a doctor. I'm going to first check with my health insurance, which is probably through my job, to understand what doctors are in my network and covered by my insurance. And then I'm going to choose one. And I'm probably not going to do that in my neighborhood. I'm probably gonna have to go somewhere and visit that person. It might be in a hospital, it might be in a medical office building. But now, because of this kind of new demographic who's less sensitive to my insurance, it's more around like, well, what's convenient for me, right? What's closest by? I need glasses, I'm gonna go to the closest retail strip center or a mall. So is this a phenomenon that is demographic driven, or do you think it's more like private equity driven, where they're doing the analysis and they're seeing, look, the wallet share for our customers is in these geographic locations, so let's spread out the footprint? Or maybe it's a little bit of both.
Yeah. Without getting too much into, and frankly, I'm not the best person to talk about why insurance industry has shifted, but what I would summarize it as, our population as a country has been aging, and we have the largest elderly population we've ever had. And so, they're guaranteed Medicare and Medicaid, that population. So the private insurance companies that typically are held by younger employed populations are effectively paying for the elderly population's healthcare services and their federal government insurance. And so that's why, maybe several years ago, the Affordable Care Act is probably what you could pin it on, is that there was a shift where over the last couple of years, premiums have gone up and up and up. So your out of pocket is maybe several $1,000s as a younger person or younger families that aren't going to spend that minimum in every year. And so they're electing to choose the lowest PPO program that they can, because they don't want to pay every month for insurance that they're ultimately not using. And so they would almost rather just pay cash. By the way, when you go buy these services cash, it's usually a lot less expensive than, for, like, if you look at it's kind of crazy, but if you look at an invoice from any of these providers, it's like there's a number if you use commercial insurance, and that number is sometimes 3 to 4 times greater than if you just pay cash. And so it's kind of a racket. Our system's definitely broken, but it just is the way it is right now.
Cool. We touched on this earlier a little bit with respect to telehealth, telemedicine. But how's technology enabling better experiences, outcomes And obviously technology is a huge overarching term here. But where, I guess, talk about it from your perspective as a service provider in the real estate space. What are the drivers of technology that you're hearing when you're sitting in kind of a pitch meeting or a board meeting with your clients, how they're integrating technology into their service delivery?
Sure. On the provider side, I mean, have you seen the new iPhones? They're, streaming 4K. It's like
Right.
The cameras have gotten out of control on mobile devices in a good way. They're readily available to just about everybody. And so that's been the big difference maker. And actually, I'm just kind of repeating what the CEO of Memorial Hermann told us when he came to visit with our group. Memorial Hermann is one of the largest systems in Texas. And, they said that's enabled their telehealth business to really work, because you can stick your phone up right next to whatever your wound is or your ailment, and even down in your mouth or whatever, and they can see things very clearly over a FaceTime or a some sort of streaming service. I think that also just what we're using right here, Zoom and Teams, has made a huge difference in the healthcare systems, and being able to again spread out and still communicate just like a lot of non-healthcare employers. And then I think also just a investment in technology. It's not just the pandemic, but even before that, there's just all these, we're going through another .com era maybe, and hopefully not the actual same translation of .com where there's a crash, but could be. But I mean, we have so much emphasis and so much capital in the technology space. And so that there's all these systems are getting approached by all these startups and not startups to kind of make them their systemness and make them more efficient, right? And it's just it's a combination of all sorts of things, I guess.
Yeah, well, I think this little quote here: patients want the same experience that they have in a banking or airline world. It resonates with me, because I would say I have kids now, so now I have multiple people I have to worry about going to the doctor and the dentist and stuff like that. And my healthcare provider has a nice interface that I could log into. I could see when my appointments are. I could hop on a Zoom with a doctor through that. It just feels like that's the way a consumer would want to have their first interaction, with a medical issue or just ongoing kind of care. And I would say that probably saves me hours every year, if not days, just because I know where to log in. I can see all my bills. I can see what I owe. I can set an appointment. I can see that for my whole family, just like I would want to log into my bank account or an investment account or something like that.
Yeah, just 10 years ago, think about it. 10 years ago, if you had a doctor's appointment for yourself or for one of your family members, it was a half a day minimum, if not an all day affair. You'd go sit in the waiting room for sometimes an hour or more, because they're always behind, right? And that's probably, you still have doctors that get behind, but it's a lot more efficient now. And you do a lot more of that. You can wait in the car, or you can try to time it and get there right when your appointment's ready to start up. And a lot of times you're just in and out real quickly. So I agree. Yeah. And
you can pay your bills online too, which is a lot easier than waiting for an invoice in the mail and then having to send a check. And did that clear? I don't know. It seems like we've taken kind of a step function forward with technology for sure. Just wrapping up here with kind of the overarching theme, like obviously you don't have a crystal ball here, but you're in the thick of a lot of this stuff. Like what does the future of healthcare real estate look like to you? Are we at the early innings of a change, or is this thing going to go straight to the metaverse?
So, fortunately for myself and those that I work with, you can't do all that much, I don't think digitally, but I will say a couple of the themes that we're seeing are as much as what can be done at home will be done at home. Big shift in like dialysis, for example, where people had, that are, have their recurring appointments that are, sometimes daily or every other day. They really don't need to be in those, and a lot of that demographic can't, efficiently get to a dialysis center. So that's just an example, but we're seeing a lot more of that. But if you're going to go to the dentist or, something like that, you're going into the dentist. And so I think that, long term, you will see more services being done virtually. I think you will see Facilities will continue to be in retail in a big way. I think that medical office buildings, they've already been shrinking, and they're going to be right in the middle of the neighborhood. They're not going to be in these big medical districts. So I do think you'll see a slowing down of like some of these major healthcare medical districts, and we have the largest one in the country in Houston. So we do a lot of work there, and I would say, like, you know, just looking across the state, it's one of the more stagnant areas of leasing activity. Kind of like central business districts and office space, right? It's just been this last couple of years have been a real challenge for business districts to define what they're going to look like in the future and how people are going to work there. I think that you're going to see a lot of mergers, a lot more mergers. We just, again, like other industries, we're seeing a lot of acquisitions, and I think you'll have kind of these mega systems that are going to be, you know, multi-state healthcare systems. Part of that's going to be, you know, a result of the Fed having a bigger say. There will be more people that have Medicare than private insurance in the not too distant future. So, you know, do we have socialized healthcare today? No. Will we have it in 10 years? Probably. I mean, there's something like it, you know, hybrid. And that'll ultimately impact healthcare real estate and who we're working for as brokers, you know, who are our clients. But I still think that, you know, America is one of the most, you know, entrepreneurial capitalistic countries in the world. And so there's always going to be a huge influence of, you know, billionaires and private equity. It wouldn't surprise me if like Elon Musk gets into the healthcare game at some point, right? He just gets into everything, and you got Jeff Bezos getting into it already, and Google. So I don't think that that's going to change, where there's not going to be new innovative ideas pushed by for-profit. I think a lot of the innovation comes from the for-profit side of things. Then the other thing that is more on the life sciences side, which we didn't really talk about today, but we do life sciences in my practice, is personalized medicine. So like bench to bed being right next to each other. So that could definitely influence real estate in some of the major healthcare hubs of the country, where you've got more R&D type of facilities immediately adjacent to major hospitals. And I think that is, you know, that's, you know, in our lifetime, we will see, you know, you and I will look back and say, you know, if we're older and we both got Alzheimer's, we won't be taking the same Alzheimer's drug. You know, it'll be personalized to our genetic makeup. And so having that, having all those trials that'll have to happen between now and when they develop that therapy will require facilities to be immediately adjacent to the healthcare hubs.
Yeah, do you envision the healthcare systems and the providers partnering with those life science companies deeper?
Oh yeah, already happening. Yeah. Already happening. Yeah, absolutely. Yep. Yeah, those two industries have historically been pretty separate, and they've never been more integrated than they have right now. And it's getting more and more like that. So yeah.
Cool. Chris, this has been great. I'm just going to pop up into the Q&A to see if we have any. Nope, we got, let's see here.
Well, I'm really happy that actually most everybody stuck around.
Yeah, that was good retention right there. Does anybody have any questions? If you do, drop them in here now. We'll wait a minute here.
Oh, here's Jeremy's question.
There we go.
Yeah, how would you respond to the statement, there will only be 20 to 30 hospital brands in the next 20 to 30 years? If you're asking me true or false, I'd say false, but I think it's not a whole lot more than 30. It might be like less than 50, right? And if we're talking about hospital system brands, yeah, maybe I can see it.
Are we excluding like university systems?
No, I think he's talking about everything. So that would mean,
yeah,
you know, that would mean that, like, you know, in Texas, I'll just use Texas because we're such a huge healthcare state. We've got probably 14 healthcare system brands in Texas alone. Just be a lot of consolidation. I don't think so. Not in 20 to 30 years. Yeah. There have been attempted mergers and that have fallen to the wayside. Baylor, Scott and White, and Memorial Hermann, 2,000-pound gorillas, tried to get together, couldn't make it happen. I think it would take a substantial shift in how the federal government is involved in healthcare delivery to have that happen. I don't think it'll happen without more changes to legislation, and that's just me guessing. Jeremy is laughing behind his computer because he knows more about this than I do.
He's got a spreadsheet somewhere predicting it all.
Yeah.
Well, my follow-up question to that is that a good or a bad thing? Is the consolidation good or is it bad? Like what is?
I don't know.
Yeah.
Yeah, I don't know. I think that anything that can get more smart people into the medical field would be better. And I would say having that kind of consolidation would probably put downward pressure on salaries, and people follow the money. And so I would say maybe bad. We already have a hard time staffing our hospitals with good nursing staff. The salaries for a nurse have never been higher. And that's a result of an undersupply of nurses. So you've had a lot of nursing schools open up around the country, and it's always a balancing act. But I would say anytime you have significant consolidation and significant influence by the federal government, and I'm not trying to be like a Republican from Texas or whatever, but I'm just trying to say, like, in general, when the government dictates your salary, doctors tend to be, especially the higher acuity ones, they tend to be pretty entrepreneurial. And you do see actually more of them splitting off of healthcare systems now. It always goes back and forth every however many years. A couple of years ago, it was like a lot of them going to work for systems. It's really hard to compete against the system. But if you're a higher acuity specialist, then you're going to make probably more money not working for a healthcare system. So you could, I should say, there's the upside.
Yep. We have another question from Navin. Typically, first mover will have an advantage landing patients when they open before everyone else in a newer developing neighborhood. Do you think that easier to use apps and digital medical records will let people switch providers more easily? And so is first mover advantage less relevant?
So first movers of a certain specialty are that's kind of the name of the game right now. So there are groups that are actively trying to grow as many locations. We've got a few customers that are like, they're not looking at the major cities, they're looking at the secondary and even smaller cities to go into, to be a first mover into that space. Do I think that patients are going to look at, if there's a way to translate success in these locations to rating systems, then yes. That'd be really hard to do though, because a lot of this stuff's private, right? There's a lot of HIPAA standards around healthcare delivery. So I think that what people are doing right now, though, I know I do it, is people look at Google reviews, and then they look at that first, and then they might look at convenience secondarily. So, I don't know if I'm answering Navin's question, but I think that's, do you think the easier to use apps and digital records will switch providers easily and first mover advantage? So that's relevant. Yeah, I mean, I do think that people will be able to switch providers easier going forward than they ever have, like we talked about earlier. So I don't think that, people are as influenced by their insurance as they might have used to be to choose a provider. So they're going to go, I think any kind of app or any kind of program that allows them to quickly identify the quality and the success and the accessibility, that will be the ones that win.
Well, we just got another one in from Morgan. Where do you see mental health care organizations fall in the physical manifestation of healthcare real estate?
Yeah, that's like probably the number one culprit of people walking in through ERs, probably because they've hurt themselves somehow or had an overdose or something like that. It's really bad. And that is something that unfortunately I've learned from working with some mental health care providers is not a super lucrative business. And it all is because of some glaring issues that the federal and state governments have to recognize. I will say there has been a very recent, the last year or two, uptick in behavioral health businesses. And so private equity is getting into that space. So if there is a way to turn profit, then private equity will probably try to fill that gap, and that's encouraging. But we have such a long way to go. It's typically a major issue for healthcare systems, but they're not really the ones that are the healthcare systems that are providing your general acute care, all your needs pretty much. That is one area that is oftentimes not met by healthcare systems, and it's a separate hospital or a separate behavioral health business that is trying to meet the needs. And there's just way more demand than there is supply of beds and resources. So, and that is something though that maybe telehealth could help with long term, right? Is just getting to a wider audience as more people, even low income people, have access to good telecommunication, phones.
Yeah, the iPhone. Well, Chris, this has been awesome. Thanks so much for your time. Thanks to the audience for joining. We hope you learned something by listening in here. If you have any follow-up questions, Chris, how can we find you?
Probably my email, chris.wadley, that's WADLEY @am.jll.com.
Awesome.
And, I kind of nerd out on this stuff, so I love talking about it.
Yeah, now we can tell. We've recorded this, so we'll post it on our social channels if you wanted to share it with anybody. If you wanted a copy of it for yourself, you can email me at matt@occupier.com. We'll get it over to you. But thanks everybody for your time today. Thanks a lot, Chris.
Matt, real quick, I didn't do a good job of plugging Occupier at all. Occupier we're using with effectively all of our tenant customers. So, and whether they want to use it or not, we use it behind the scenes anyway, just to stay organized. So really appreciate you guys, creating a program that was a void that needed to be met. We have a version of it that you probably are aware of at JLL that's probably way too old. And so you guys have created something that, now that is available to brokers and transaction managers. And we really enjoy the ease of use of it. You didn't pay me to say that. I just wanted I wanted to make sure that I thank you for having me for this WebEx, and appreciate you, giving me some time to talk.
Yeah, no, I appreciate it. And, it's been taking every ounce of my willpower to hold back and trying to plug Occupier, but you did it for me. So thank you.
Yeah.
If anybody does want to learn more about Occupier, hit up occupier.com. Again, you can email me at matt@occupier.com. We work with a lot of tenant rep teams that are doing high transaction volume in providing services to their tenants through collaboration. That's Occupier. But thanks again, everybody. You know how to find us. Signing off. Thanks again, Chris.
Thanks,
See
man.
you.